Good evening. We are completely timely, and I'm delighted to have such a distinguished audience and participation. We shall approach somehow apparently different from balneology, although everything is connected. And we are in the era of the progression of digitalization, and the consequence is the appearance of artificial intelligence. We are extremely honored and delighted to be partners in a very important European consortium with 15 partners from 9 countries, which is led by the distinguished fellow of ours, Gunnar Cedersund from Sweden City. And he will lead this roundtable, and I'm sure you will find out a lot of things general, but also the stage of development of our European project, which is acronym is Stratify AI. Dear Gunnar, please take the chair.
And we try now. So now it's the echo. And there's no way to get away of the echo. Yeah, exactly.
You know, again?
We try without the mic.
No, with the mic.
Okay. What about now?
Echo is gone.
Is that right? All right, echo is gone. Yo. Okay, so welcome again, everybody. And I'm still very happy to be here on the invitation of the team from Scuba and Professor Honose. So we are a part of the same EU project, which is called Stratify. And I will give an introduction now to Stratify and to something called digital twins, which is a computer copy of a patient. So it will be here, and there is also here a little summary of Stratify. If you sort of forget the basics, you can look to your right. Okay, so Stratify, it says also there, the title of that is Continuous Stratification for Prevention, Acute Treatment and Rehabilitation of Stroke Patients. Patients with a stroke, using digital twins and AI. And then the question is, what are these digital twins? So you see them here, and let's see if I can point. Yeah, so here you see a person, and here you see a digital twin of the same person. So you see here in the digital twin, you can look inside the different organs, you can look inside the brain and the vessels, and then you can also see how they change when they do things, when they go for a walk, maybe when they do a spa treatment or some balneological treatment. And I will show how it's built up and how we add new features. Because most of the things that we talk about in this conference, we don't have yet. So I will talk about how we can add that and how we can add these type of treatments that we're talking about in this conference as part of an integrated ecosystem where healthcare and other actors are sort of part of an equal footing, and they can communicate with each other and integrate with each other. So my name is Gunnar Cedersund. I am the coordinator of this big project, and I will introduce the various actors and the various things going on in this project. So to start with, I want to introduce you to a concept called M4 Health, which is two things. The first thing is that it's the idea that we need a new model for health. So we need to restructure our healthcare systems to become more integrative, to involve new type of actors. So I come from Sweden, and in Sweden, as in many other countries, we have big demographic changes coming up. So the number of 80-year-olds and higher will increase by 50% in 10 years. And those account already for 50% of the healthcare costs. So there will be a dramatic increase in cost. And we need to bring in new actors that can help to deal with this big societal burden. So that's one thing, that we need to sort of restructure our healthcare system, bring in new type of treatments. And the second thing is that I will talk about how we can combine advanced technology and AI into this. And there's the type of AI I will talk about is of a specific M4 character. So there are 4 M's in this description. The first is that it's mechanistic. The second, that it's multi-level, multi-timescale, and multi-species. And I will go through each of these M's during the presentation. So by the end of the presentation, these 4 M's will hopefully be crystal clear to you what they mean. So basically what we do is to lay the puzzle of the human body. So we have different hypotheses and understandings of how different treatment works. This is what we talk about in most presentations in this conference. And often we also talk about different types of data. It might be some images that you take of a person either on the outside or using MRI on the inside. Might be some time series, might be some omics if you take a blood sample, for instance. So all of these can contribute to building this puzzle, this description of the human body. And then we want this to be useful for a variety of different actors. When you go to school, when you go to a gym, when you develop drugs, and when you go to traditional healthcare, and when you go to systems that may or may not be fully interconnected with the traditional healthcare. And I think balneology is sort of, depending on the country, it's sort of part of traditional healthcare or not. And there are many other things that are of this nature. Yoga and regular gyms and personal trainers, they don't have a formal medical training, but they still work with health. And if you can bring your digital twin, your computer copy of yourself, to all of these different places, you can share knowledge and you can sort of integrate them to be part of the same ecosystem. So that's the basic idea. And so the basic idea is to have a digital twin that follows you across your health journey. And again, a digital twin is a copy of something. And here you see a copy of a tree. And this tree is symbolic both of health and of a sort of decision tree. And here it looks almost like a circuitry, so it's a computer type of tree. And this is the logotype of the spin-off company that we have that turns what I'm talking about now from a research project to a product that you can buy and that you can use in any way you want, to sort of move it from research to actual society and actual healthcare. And the goal here is to inspire people to make sound medical decisions. And sound in Swedish is Sund, and that's the name of the company. And it's also part of my last name. So my name is Cedersund. And this tree that you see here, it's a cedar tree, and cedar is the first part of my last name. So it's a sort of symbolic digital twin of my last name, you could see. So my last name means healthy tree. So I'm a professor at Örebro University, and my main research group is at Linköping University, both in Sweden. And my research group is also has a logotype that you see down here. And it has two parts. It has a box that's open. And this is because it's mechanistic. You can look inside and see the mechanisms. You can see the processes happening. And this is typically not the case with AI, artificial intelligence. Typically, it's a black box. You can't look inside. And we can also, unlike typical AI, see the uncertainty, how well determined different predictions are. So that's symbolized here by the core in the middle. But we also combine it with traditional AI into hybrid models. So this is sort of basically the overall goal, to have a digital twin that follows you from prevention to acute treatment and rehabilitation, combining a variety of different actors into an ecosystem by having them all use a digital twin. And I will talk about what are the criteria to have a digital twin come to your place where you have your treatments. What are the scientific criteria that needs to be met to be able to describe the processes and know that it's sort of scientifically proven, and also how can it in practice be integrated. So that's sort of the goal with the presentation. And to give an overview of this project, which then will be followed by more specific presentations that will go through different specific aspects of this overall project, this Stratify project. And in the end, there will be a roundtable presentation. So all of this will take, in total, 2 hours. And I will talk for around half an hour. Okay, so let's go. So before I forget it, this is my research group. It's a little bit bigger now. This is a couple of years ago. Here is some of the main funding. And the funding we're talking about now is from the EU Horizon Europe. So these digital twins can be simulating immune-related things like stress and yoga, brain research, cognition, stroke, which is the main thing of this Stratify project, but also high blood pressure and diabetes, and also be used for a wide variety of other things. And we already have lots of collaborators. And these collaborators are typically either medical doctors or biomedical researchers that have data for how different aspects of the body work or how different treatments are impacting patients. And then we take those data and that knowledge and bring it into our computer models. So there we need new collaborators to add your type of treatments and your type of data. Okay, so this transition from one healthcare system to another. So at the moment, in most parts of the world, it's quite fragmented. So you have different clinics that have their own data, and they often don't even share data from one clinic to another. So when a patient moves from the acute treatment and the neurosurgeons to the rehabilitation center, often the data doesn't follow. And when you move from a primary healthcare center doing a preventive checkup, you generate data for that checkup situation, but then it's not integrated into the rest of the system. And this is just within established healthcare. If you then talk about other actors like personal trainers and gyms and spas and so on, they are even less integrated. So we have a very fragmented system, and we want to develop this digital twin where we also have a private data vault where data from all of these different sources, from journal data and qualitative data and sensor data, come into a personal data vault. And this then follows the digital twin, it updates the digital twin, and then the digital twin goes to all of these different places. This is sort of the goal, to build up this ecosystem, patient-centric ecosystem, which is, and where balneological treatment facilities can be added. And this is what we'll discuss sort of in the end, how this can be done after you have all of the information about how things happen. And this is part of a transition to something called P4 medicine, which is 4 Ps. It's predictive because we predict what will happen before you do different things. You can simulate them in the computer. It's preventive because you can start to treat things before they have actually manifested, because you can see that they are about to happen. It's personalized because this digital twin is specific for each person. And it's participatory because you really want to engage the patients to be involved in their own care, understanding their own care, and also engage many other actors. So here we have the different talks. I will now talk about these digital twins. And then the team from SCUBA will talk about the scientific evidence of balneological treatments and how this connects to other treatments in traditional healthcare. So we sort of have that basis. And then for the integration, it's very much an integration of data. So talk 3 will be about this private vault. Talk 4 will be about how we integrate these different data sources that come from different places, and they need to be made interoperable, so comparable with each other. That's talk number 4. And then the last talk will be about the Romanian system that deals with healthcare data, so the electronic healthcare system. And after we have all of these things on the table, then we have the roundtable discussion, and then you can all ask questions. So that's sort of what will happen during the next 2 hours. Okay, so let's have a look at different types of data. So this is a typical clinical study where we examine some patients at some time point, and then at some time point later, maybe 2 years later, maybe 10 years later, maybe 2 weeks later, we examine what has happened to them. And then you have some average behavior. Here, the average patient goes up a little bit. And then you can add covariates, which is basically additional information about this particular patient, which allows you to see a little bit who is more likely to go up more or go up less. But in these type of studies, which are very common, then you can also have these type of individuals that go in a completely other way. So here, this person decreases. And in this particular case, it's because this person has changed something in his lifestyle. So between this time point, when we know what he was doing, and over here, he has decided to start to exercise regularly, for instance, or change his diet, or do other types of treatments. And if you don't know this thing, what has the person changed during these 2 years, then there's no way for you to predict that this person is going to have this very different outcome, because you're missing the information. You're missing the information about what the person is doing between the time points. And this type of data is typically not available in these type of databases like UK Biobank and so on, where they have very well characterized information at one time point, and then they know which of those had a stroke, but you don't know what they did in between. And often you don't have this type of data in healthcare systems either, especially if they're relatively healthy. So that brings us to this personal data vault, where we have the ability to integrate this different type of data, what the person is doing, which is typically apps and wearables, or own data, own observations, or diaries, or the person making observations, maybe talking to their AI friend, talking about what they did on a regular basis. You can integrate that together with a copy of the electronic healthcare records, so the journal data from the hospitals. And these type of data might come from a spa treatment facility or something like this. Or at least some of those when they are there. But those type of data are typically not integrated into the electronic healthcare records. But because of GDPR, which is a European law many of you have probably heard of, that causes lots of problems for many individuals, but it's also essentially sound. It has a benefit. And that is that you can ask for a copy of any data that has been stored about you anywhere. You can ask for a copy of that. And when you have that copy, you can put that into your data vault. And the technology that Jesper Felenius will talk about in talk number 3 is about this data vault, how it works and how this is secure and so on. And then this can be used to, this totality of data can be used to update the twin, and also to be shared with others. So a medical doctor at a spa facility, or a personal trainer, or a health coach, or anyone, or a relative, anyone that the individual himself or herself decides that he or she wants to share the data with. And then these type of data also come from different places, meaning that you can't use traditional statistical models to to analyze the data. So you need to have a hybrid approach where you have these digital twins that are mechanistic to analyze the type of information where you know what they are doing and how things are changing in response to this. So this type of data. That goes into here, and then omics and imaging or traditional cohort data goes into the machine learning part, and then they share information with each other. This is the hybrid approach, which I will explain to you during this talk how this works. Okay, so let's go into it. So basically what we've been doing in the last 20 years, 25 years almost, is to develop computational models. So here you have references to scientific journal papers for all of the main organs in the human body, blood flow and liver and brain and fat and muscle and so on. And we have integrated those into an integrated model that can become patient-specific by tuning it to patient-specific data. And here we have this hybrid combination again. And then we're also nowadays developing apps that can be used in different situations. So this is sort of the key publication sort of leading up to the Stratify project. And then if we have this digital twin in the middle and we look at different organs, look at different parts of the body, let's start by looking at the head. So here we have a face. So this is an AI. You can talk to your digital twin. It will respond. It will remember you. It will have an emotional response depending to what you say. And the difference between the AIs that you typically see and this one is that this one has a brain behind it. So you can see which parts of the brain that are active when it's doing all these different things. In the same way, you can look inside the heart and see the blood pumping, and you can see how that changes when you exercise or when you sleep or when you take a blood pressure medication. And you can see how the biomechanics of the person is changing when it's doing something physical. So here is a digital twin of me that is doing some kind of dance performance. And this is me without my clothes and my skin. So you can click on these different muscles and see the forces and the impact it has on joints and so on. And then if you do dietary interventions, you might want to look inside the liver and see here, for instance, how a fat droplet is disappearing because the changing metabolism in the liver in response to your changing your diet. So all of these are visualizations of underlying processes that are described in the computational models. And how do you describe these processes? And how could you, if you have some data or some treatment, some patients, how could you add your knowledge and your data into the twin to have your treatments be simulatable in the twin? It's in this way. So you need some data. And if it should be this thing in response to what you're doing, the best if it's time continuous data. And then you need some kind of hypothesis for how this works. How is the time evolution of this happening? And then we formulate this hypothesis into ordinary differential equations, which if they cannot describe the data, then we have to reject them or reformulate them. But then we always see, can they predict new data before we add them to the big model and use them, for instance, to simulate what happens if you take a drug or some other treatment. So here we see 3 different simulations: healthy simulation in blue, type 2 diabetic patients in red, and then the resulting improvement here of a diabetes drug, which is the dashed red curve here. So this is an example of you using the twin. But this is the process, and I will go through a little bit how this works, so you can sort of make it clear if you have some information or some data, how you could do the same thing in collaboration with us or in collaboration with somebody else. But the key idea is that this is sort of basic science. This is understanding how things work, and this is using it in end usage situations. So if we zoom in now on the very detailed aspect, this is inside a cell. So here we have the cell membrane, and here we have insulin, a hormone, coming to bind to an insulin receptor, which becomes phosphorylated. So each of these are different reactions, which correspond to different terms in the equations. So the equations describe these type of processes: a binding reaction, a phosphorylation reaction. This becomes activated as a kinase, which leads to another phosphorylation reactant here of another protein. So this is sort of the lowest level of the processes included in the twin. So this particular paper was, part was tested 5 times. We tested 5 times if we could predict completely new things before we were happy with it. That was published in 2010. In 2013, we had gone to the end result, which is insulin leads to increased glucose uptake. And we also characterize how this goes wrong in type 2 diabetes. So that's built on these type of data. And this is now in vitro data. In one of the opening talks, we heard about different types of data. This is data on cells. So here we take just one of these data and just look at the quality of it. So here we add insulin to a cell and see how it goes up. The phosphorylation of the insulin receptor goes up and then it goes down. And the data here, the experimental data are the red error bars, and the simulations with the twin is the blue curve. And you see they behave in the same way, go up and then they go down. And the uncertainty is this lighter blue area. And do I have the time? Just approximately 20 past. Perfect, thank you. Here, if you want to do these type of things, as was mentioned in one of the first keynotes presentations, it might be that you add some kind of pressure or some kind of mineral water or something to some cell to see on a cellular level how they respond. And then you have the organ-organ communication, where you have these type of fat cells here talking to other cells. For instance, the pancreas, which produces the insulin. And then you have patient data. So here we have a meal, and we see the organ, how that is taking up glucose in response to the meal and how it goes down. And again, we see a close resemblance between the data in red and the simulations in blue. So this particular model has been approved by the Food and Drug Administration to replace certain animal experiments in type 1 diabetes. And then on the highest level, we have disease development and weight change and so on. So here we have these 4 M's. It's multi-level because it's from the whole body level down to inside the cells. It's multi-time scale because these things inside the cells are in minutes or sometimes even seconds or milliseconds if we look inside the brain. And disease development typically happens over months or years or even decades. It's mechanistic because we describe these processes, how different actors are talking to each other inside the body. And it's multi-species because we have a corresponding one also for mice and primates. Yes, so going to furthermore understand this type of data. So now we are looking inside the liver here. So the previous model that was approved by the FDA, it only describes the crosstalk between glucose and insulin in the blood. But the liver, here we have conversion between, for instance, amino acids and glucose. This particular model was published 2 years ago, and it's based on similar data that you typically do in a clinical study, where you do something, do some kind of treatment. In this particular case, it's just a meal, and you measure how, in this particular case, the liver is producing glucose. It's called endogenous glucose production, and the glycogen level. So we can describe this data, which is estimation data. We can correctly predict what happens in another cohort. So these patients here, they have type 2 diabetes and they are of a certain age. These are younger, they don't have type 2 diabetes, but we can convert between those in the model. So you see that we can correctly predict here in blue what happens, which are the error bars. And then we always try to find some new unexpected predictions. So in this particular case, the only data we have is for short-term fasting, 6 hours, and where we see the glycogen go down a bit. But then we can extrapolate in the model. We can ask the twin, what would happen if you would fast for 48 hours instead of 6 hours? And what would happen if you drink a protein drink after that? Well, before that, basically nothing happens because the protein is just used to build muscles or produce energy. But here, because the glycogen is so low, gluconeogenesis has been so upregulated that even though you are sort of degrading your muscles, you would prioritize to produce glucose, the digital twin says, from the amino acids. And that's exactly what we see. The prediction here in blue and the data say the same thing. After around 1.5 hours, we will have increased our plasma glucose level with 1.5 millimolar before it goes down again. So this was a completely new type of prediction that the model could describe because it describes the processes. So these type of time series data is typically the best thing to add. So if you want to test some kind of treatment, if you can collect this type of time series of what happens over time, then it's ideal for adding your treatment into our digital twins. And as part of Stratify, we'll do a large study where we measure many of these type of processes in parallel, including also cognitive processes. So we also do the brain. I won't go into that much now, but we look at various aspects of the brain, as I showed you in the beginning. So we have validated these models, and they have translation from animals. So let's talk about Stratify. So we have this large-scale data, the one where we have a few time points only. They are located in different places. And then we use something called federated learning to have the model jump around between these different data places. And this forces us to harmonize this data. And this is what Kati will talk about in talk number 4, how we harmonize this data, how we make them compatible with each other. And then these type of data and all sorts of other data, for instance, from electronic health records, will go into the personal data vault. So this is talk number 3 and talk number 5. And this goes into the digital twins, which is what I'm talking about now. And then talk number 2 will be by the medical doctors in Scuba about the scientific evidence for medical treatments, balneotherapeutic treatments, and the relation between those, which is sort of the basis for the discussions in the end. And we also in Stratify do prevention, and I will talk just very shortly about that now in the end here. So here we have an example of this integration. So in the first steps here, we are in a medical facility. So this is a primary healthcare center. And here either a medical doctor or a physiotherapist or something like this is talking about risk factors together with a patient before they have any severe symptoms. These are, you have a little bit too high blood pressure, you exercise a little bit too little, maybe you don't sleep so well. So there are different risk factors here, which are the different rows. And the digital twin is there to help explain those things and also explain what you can do to change that, what type of treatments you can do to change the risk factors. You can exercise more, you can eat better, or take other types of treatments. So all of this is within healthcare. But then you have your twin, and we'll allow the twin to follow the patient home. And then comes another phase where here there will be coaches and personal trainers at gyms that are not part of established healthcare, but because the twin comes with them, you have all of the information from the healthcare conversation that happened in the primary healthcare center is available also to the personal trainer. And we train these personal trainers, these health coaches, to understand that information and to keep working on those goals. I should exercise more, I should eat better. They will help with that sort of phase. And this could, of course, be other actors as well. But this is the basic idea. And we'll test this on 200 patients that do this whole process, and we'll compare it with 200 controls. So we can simulate these type of different scenarios. What happens if you eat a little bit more, 400 kilocalories more than you do now? Your weight will go up, and you will probably have developed diabetes here, so your insulin levels will be lower over here 40 years later, and glucose levels will be higher. In contrast, if you exercise just a little bit more, eat a little bit less, your weight will go down, and you don't have these problems. And these type of data then go into the machine learning model, the risk model, where we can simulate the corresponding risk of having a stroke. So this is the hybrid approach. And the assumption is by seeing these type of different scenarios, you will understand better, you will be more motivated, and the treatment instructions will carry across in a better way, be followed better. So here we have another example, and now we are already in an app, and we are at the very end of the presentation. This is the first app where we have a person called Gunnar, who is 44 years old and have high blood pressure. So then we can simulate two different scenarios, one where he takes a blood pressure medication and one where he doesn't. So now we click on simulate. I want to show this. It's sent to the backend where the twins are, sent back to the phone. And here we see the treatment. The blood pressure goes down, systolic blood pressure, diastolic blood pressure. That's the green curve. And this is the corresponding risk of a stroke. And in the thing in Stratify, we are developing a more advanced version of this. So you don't always have to look at curves, which might be too abstract for some people. So instead, you can do a face scan that you convert to something that looks like you. And then instead of seeing a curve that the weight goes up or down, you can actually see your body change. And instead of hearing that you should do different types of treatments or that you should exercise, you can see yourself do these type of treatments, or you can see yourself exercise. And instead of just hearing that this is good for different organs, this is good for different aspects of your body, you can make your digital twin transparent and look inside and see these different types of things. In this way, you can sort of design your ideal future self. This is the way I want to be in the future. And then you can ask the twin, which pathway will lead me to this future? What type of changes do I need to do? And then you have the goals. And when you have the goals, then you just need the help from the health coach or from the personal trainer or something like this. And this can integrate a wide variety of different things so that you can bring your twin with you to different places. And my final example here, before we hear all these other presentations, is an example of something completely different. So here we have me playing the piano. I'm giving a concert as a conference, such as this one. We have people in the audience. And here we see one of the best ballet dancers in the world. She performed in Carnegie Hall and so on. So she's dancing. And a little bit later, here we see digital twins also dancing. And now this is taken with the phone camera, so the quality is not so good. But so we'll zoom in. So here we see, this is the digital twin of the dean of the medical faculty at our university. This is the digital twin of the CEO of one of our biggest spin-off companies in Sweden. And this is a digital twin of me. And they are all dancing to the music. And you can all the time look inside the body and see what happens. And you can simulate backwards in time and see what would the twins have had to do to be able to do these quite advanced movements, type of stretching, what type of exercises and so on. So in that way, you can sort of learn about your body when you do different things. When you go to a concert, when you go to the gym, when you go to a spa treatment soon, and when you do anything, the imagination is the limit here. So that's what I wanted to say as a sort of overview. Now, I don't think we have time for that much questions now, but we'll go on to the next presentation. And then we have all the questions in the end, where we have the roundtable presentation. Okay.
My fellow Dr. Cristina Popescu from Scuba staff will present.
Yes.
Will present our expertise right now within this project, because we are one of the clinical partners aiming to support the clinical component of rehabilitation, but I shall keep a conclusion for the last, because a very original and very specific item introduced within this project is completing the circle from rehabilitation, which is at the end, back to prevention. But let's see.
Thank you for the introduction. Welcome, everyone. Nice to see you all here and to hear you here online. I will present you a preliminary database on stroke cases for digital twin training in the Stratify project. And this presentation provides an overview of the preliminary database on stroke patients being developed for the Stratify project, which aims to leverage artificial intelligence and digital twins to improve neurological rehabilitation. This database will serve as a foundation for training AI models to personalize and optimize stroke rehabilitation for patients. There are several treatment paradigms for the rehabilitation, including physical therapy, occupational therapy, speech therapy, and/or cognitive behavioral therapy. All their selection depends on the type and the severity of the condition, as well as the individual needs of the patient. So additionally, modern technologies such as virtual reality and digital twins are increasingly being used in the neurological rehabilitation process to improve treatment outcomes. We all know that neurological disorders such as stroke, Parkinson, multiple sclerosis, and traumatic brain injury affect millions of people worldwide and have a significant impact on their quality of life and independence. Neurological disorder can cause a variety of symptoms and dysfunctions, including motor, cognitive, sensory, or language difficulties. Neurological rehabilitation is a complex and multidisciplinary process, often involving an interdisciplinary team of specialists such as rehabilitation physician, physiotherapist, occupational therapist, speech therapist, neuropsychologist, and other medical professionals. The goals include improving functionality and mobility, reducing cognitive sensory language, so swallowing symptoms and disability, facilitating adaptation to changes in health status, and enhancing the quality of life of these patients. Why AI, artificial intelligence, is important for neurological rehabilitation? What brought us until now and what could bring us? A precise diagnosis and prognosis. AI systems can rapidly and accurately analyze clinical and imaging data, facilitating early diagnosis and prognosis of neurological disorders. And this enables us to initiate a treatment as early as possible. AI can analyze data about each patient individually and generate personalized treatment plans tailored to their needs. This ensures a more efficient and precise approach to rehabilitation, although in a balanced approach with the standardized related paradigm generally represented by the use of the guidelines. Also, AI system can monitor patients' progress in real time based on data obtained from various sources, and this allows for rapid adjustment of treatment plans and provides us constant feedback for patients and healthcare professionals. And also the use of AI would lead to more efficient resource management and cost reduction. We all know that stroke are a major cause of disability and the second leading cause of death worldwide. It occurs when there is a disruption in the blood area. So this disruption can result from either a blockage, that's the ischemic strokes in the blood vessel, or a rupture in the blood vessels, that's the hemorrhagic stroke. The rehabilitation after a stroke is crucial for improving the quality of life and recovering lost functions. Rehabilitation begins in the neuromuscular earlier, in the neurovascular emergency unit, focusing on stabilizing the patient's condition and preventing complication. That's the acute phase. After that comes the earlier rehabilitation, started in specialized center like ours, aims to address a range of issues, including mobility, cognition, communication, and daily living activities. And after that comes the long-term rehabilitation process, continues to focus on improving function, preventing secondary complication, and facilitating the patient's reintegration into their daily life. The rehabilitation physician is the one who oversees the entire rehabilitation process, coordinating the multidisciplinary team. The physical therapist, the kinesiophysiotherapist, he's the one who helps improve mobility, balance, and gait through specialized exercise and techniques. The occupational therapist assists the patient in relearning or improving skills for daily living activities. The speech therapy works to improve communication, swallowing, and oral motor functions. The multidisciplinary team also includes physiotherapists who apply physiotherapy procedures like inhalation, electrophoto, cryomechanic therapy if necessary, but also psychologists, social workers, and nurses who provide and ensure a continuity of care. The most frequently stroke rehabilitation needs are in motor and speech deficits, in cognitive and emotional difficulties, and in swallowing balance programs. Rehabilitation must begin as soon as possible. About the mobility training, gait training, and wheelchair independence are essential for improving physical functions. Interventions targeting speech and cognitive impairments such as memory and attention are crucial. But managing complications like neuropathic pain, spasticity, sphincter dysfunction, visual disorders, and mood disorders are also very important. Preventing secondary complications is also an important issue. Malnutrition, pressure sores, aspiration, urinary tract infections, contractures, excessive muscle wasting, agitation, mood disorder, depression. We all should focus on personalization, on continuity of care, coordinating care across different specialties, and of course on collaborating. Involving family and caregivers in the rehabilitation process is also very important. How does our rehabilitation program look like? So we offer 5 hours of group or individual therapies per week, including physiokinetotherapy, occupational therapy, speech therapy, drug-specific treatment, pain or neuropathic pain management, spasticity management with orthosis to improve walking, or medication with baclofen, with injections with botulinum toxin, or physiotherapy like shockwave for decreasing the spasticity. And also physiotherapy for pain, laser therapy for stimulate the muscle, electrostimulation for contractures, the paraffins applications. Once again, physical therapy aims to restore physical function and mobility, helping stroke patients to regain muscle strength, coordination, and balance. Therapists use a variety of techniques, including exercise, stretching, and the use of assistive devices to improve the patient's ability to perform everyday activities. Occupational therapist assist the patient in developing skills necessary to perform daily tasks such as dressing, feeding, and personal hygiene. As the speech therapy works to restore the language comprehension, the ability to chew and swallow food safely. Breathing and speech exercise, as well as the swelling management techniques, are used to minimize the risk of complications. We use a lot of methods, starting from posture, motor control technique, Bobat method for decreasing spasticity, improving balance and coordination from sitting down, sitting short and at the edge of the bed, and also setting through imbalances in different planes by successively shifting the weight of the body from the normal side to the paretic one. We use walking training, breathing exercise with or without technical aids. This is a video from a patient admitted in our clinic. He had a stroke at 35 years old. This is after 3 months after rehabilitation. He performed the cycling at the motormed. Regarding the 3 types of motor control techniques, most of you know, but in the passive movements, the muscles are not actively contracting and the movement is driven by an external force. This technique is often used to maintain joint range of motion and prevent contractures. In the passive active movements, that involves the patient actively assisting in the movement while an external force or a therapist initiates and guides the movement. This technique aims to improve coordination, muscle activation, and motor planning. And active movements involve the active contractions of muscle to produce motion without any assistance. We use often the Kabat techniques that utilize sensory stimulation and proprioceptive input to induce muscle contractions. For decreasing spasticity, as already said, we use the Bobat method. You see the difference after a month of rehabilitation from the left to the right pictures. And before starting walking training, always the physiotherapist has to evaluate the patient's specific needs and tailor the walking training program accordingly. Therapists provide the necessary support and guidance using aids or partial suspension as needed to facilitate safe and controlled walking. And the training program progressively becomes more challenging, allowing the individual to regain strength, confidence, and independence in walking. About the walking rehabilitation, we always start with sustaining the patients, walking between parallel bars, learning symmetry, orthostatic balance, shifting body weight onto the affected lower limb. After that, without the parallel bars, and in the end, ascending and descending stairs is the final goal. In the walking training techniques, we should always, that's the movie, the video, the same patient walking, we always have to maintain a proper body alignment. Is crucial during the walking to ensure efficient and safe movement. And practicing shifting exercise helps individuals with hemiplegia improving balance and stability during walking. And coordinating, of course, the movement of the affected and the unaffected limbs is a key focus in the other patients with hemiplegia. We also benefit from speech and language therapy in our unit, from occupational therapy, from physiotherapy, electrostimulation, laser, shockwave you see in the pictures. And coming back to AI, the integration of AI apps and digital tools in stroke rehabilitation holds a promise of more personalized and effective treatment plans tailored to the needs and characteristics of each of those patients. The stratified projects come, which this database I will talk about will support, represent a collaborative effort to leverage the power of AI and digital twins to advance the field of neurological rehabilitation. There are some limitations. Some aspects of stroke, such as long-term prognosis and treatment response, are influenced by a wide range of factors, and interpreting this complex data can be challenging for AI. Also, AI requires large and high-quality data to be trained effectively, so obtaining precise and correctly labeled data can be a challenge in the medical field where data may be inconsistent and incomplete. And also AI algorithms may be trained based on data from specific population or demographic groups, which can lead to incorrect generalization of results in different contexts. So there is a need for better integration of AI technology into existing healthcare systems. So Stratify project is a collaborative project involving a total of 15 different entities in EUI who have joined forces to develop and validate the platform for continuous stratification. The Stratify project will develop this semantic harmonization to facilitate the meaningful reuse of data from hospitals. And its aims is to improve stroke management through the development of digital twin technology. In this project, we will validate the models in the platform technically using 6 dedicated clinical trials. And about the database, the purpose of it is to compile data related to stroke cases, including patient demographic, medical history, diagnosis, and treatment modalities. This database contains detailed data on 152 patients who have consent to participate in research studies. The data base include essential demographic information about each patient, such as age, gender, ethnicity. These data help us understand the diverse population we serve and identify any potential disparities in access to care or treatment outcomes. It also includes comprehensive anamnesis and medical history information for each patient, including past medical condition, previous treatment, allergies, family history of illness, as well as their living and working conditions and any related behaviors like smoking status and alcohol consumption. This all information is crucial for understanding the individual risk factors and comorbidities. The database also captures the primary and the secondary diagnosis, and this information is crucial for accurate coding and for tracking the prevalence and patterns of different stroke. The database includes a detailed chart summary for each patient, which provides a comprehensive overview of the patient clinically course. This information is valuable for continuity of care, for understanding the long-term outcomes of our stroke interventions. And finally, it contains the daily progress notes for each patient. So these detailed records allow us to closely track the patient response to treatment and make timely adjustment to their care plan. Evaluation scales such as Ashworth scale, Penn scale, Bartel are used to quantify the patient's level of spasticity, spas frequency, and activity of daily living. The ranking scale and Glasgow-Altman scale are used to measure the degree of disability and overall the functional outcome for the patient. The Montreal Cognitive Assessment, the quality of life measures are used to evaluate the patient's cognitive functions and overall quality of life, which are crucial factors in stroke management, and also the functional ambulation categories and the disability rating scale are used to monitor the patient's progress during rehabilitation and the level of support required for activities. This database captures always information about the stroke diagnostic, including the type of it, ischemic or hemorrhagic, the data of that production, and the specific symptoms present at the admission. Also records the treatment administered to each patient, the results of laboratory tests, also records the data from any continuous monitoring devices to track vital signs like blood pressure, pulses, or saturation. So this stroke patient database provides a valuable resource for collaborative research efforts, bringing together clinicians and researchers and data scientists from various disciplines. The multidisciplinary approach allows us to leverage diverse expertise and perspective to gain a deeper understanding of stroke. By creating this virtual model of each patient with stroke that accurately reflects their unique anatomical, functional, and pathological characteristic, this personalized approach offers a deeper understanding of the condition and the individual needs of these patients. As the digital twin model is updated with new data and feedback from the patient's care journey, it can be continuously refined and improved, leading to more accurate predictions, better informed decision, and enhanced stroke care delivery over time. Of the only 6 clinical studies to be performed along the Stratify projects, our study takes place in the clinical study 6 in the neuromuscular rehabilitation clinic from Scuba in 2026. And then we will investigate for the first time how patients and medical staff experience the usage of this Stratify platform across all stages of stroke. We already submit the study approval along with the methodology for testing the application developed on the real subjects to both the local and the National Bioethics Commission. These are the approvals. And in the conclusion, why this app can be used for patients with stroke. Patients can use this app to perform prescribed exercise at home. Or the app can offer cognitive exercise to help patients to improve memory, attention. The app can include features to remind patients to take medication. Patients can access educational resources within the app to learn about stroke and lifestyle changes. Healthcare professionals can incorporate this app into their programs, the rehabilitation program, monitoring these patients' progress and adjusting treatment accordingly. Also about the community support, inclusion of forums or support groups within this app can foster a sense of community, enabling us to share experience and advice. And also the app can engage family members, keeping them informed about the patient progress and offering ways for them to support the rehabilitation process. So once again, reiterating the importance of this initiative, the initiative to utilize digital twins technology in stroke management represents a significant advancement in medicine by integrating comprehensive patient data into virtual models. Digital twin simulation offers valuable insights into patient, and overall, the initiative impact extends for beyond individual patient care, and it represents a collective effort to advance management and provide better care for stroke patients worldwide. Thank you.
So the next presentation will be online, and it will be about this personal data vault, and it's Jesper Felenius from the company Z2 that will give this presentation. Do we have Jesper with us?
Yes, I'm here, but I cannot start the video. It has to be
Somehow
okayed by the presenter.
Yeah.
And I also need that to be able to share my presentation.
I think you are being promoted here as we speak.
In progress. No, so now I think Jasper, you can share your screen. I already noticed to multiple participants here simultaneously. Can you try to?
So Jesper, do you hear?
Yes, I can't start the video because the host has stopped it. No, sorry, I can't. You have to make the authorization within the Zoom app.
Yeah, basically the same happens to me. So
Yeah, I was just gonna ask if Catalina could, but she couldn't.
What happens if you make them forward? How to make them forward? Yeah, that. Yeah, what is it called?
Okay, now you can try to.
So try now, Jesper.
Yeah,
Good.
great.
So then,
Awesome.
Jesper, the floor is yours.
Yeah, okay, thanks. Hi, everyone. My name is Jasper Filenius. I can't see you all, but I can see the panel. Professor Gullio, thanks very much for having me here today, and all the colleagues with Gunnar, etc. So, okay, we got a limited time here, so I think I'll just jump into it. Gunnar, is that your?
Perfect.
Yes. And I will try to do the screen sharing. Does it work?
We can see it well.
Okay, good. Do you see it in presentation mode?
Yes. Yes.
Perfect. Very good. Okay. So the title I got is yes. I'll just start the timer here also. Bring a copy of all health data that are generated about you in your own personal data vault. My name is Jasper Filenius. I'm a Swedish entrepreneur. I have a company that's called Z2 Invest here in Sweden and work over Europe with these questions. Gunnar has introduced the basic stuff, I think, already, but I will give you some more detail and also put it in a perspective of why we have developed this since about 2015, using internationally renowned cryptographic people and software engineers, etc., to make a possibility for us humans to be part of the AI era in a good way, sitting in the front seat, not in the back seat then. So why do we need individual-centric health data in the first place? We touched about it a little bit before. This is a parliament decision here in Sweden about why integrated person-centered care, and also the United Nations and WHO has a regulation regarding this, as you probably know. For us here, we will have a 49% increase actually of 80 plus in only 6 years by 2030. We will also have those multi diseases going on, of course, as we get older. We're also living in a digitalization era where we are getting used to digital tools in a way that's going very fast. And also this creates a demand of how things should work for us, what kind of services we should expect from all this. And also, of course, we got equality and other stuff regarding this too. So from a development perspective, what has to be changed? Well, there is a movement on from focus on organizational and legal entities to the personal and the relationship, really designing a service process with the individual in the center here. Also from isolated care and welfare interventions to kind of coordination based on the focus of the person with people around. We're using the relatives, we're using coaches, etc., in a more wide meaning here. And also because the state won't be able to do it, we have to trust on persons around and support this in different ways. Also, there is the from reactive to the proactive dimension, and also the individual probably has to take a larger responsibility regarding one's health and understanding of one's health, etc. So kind of from residents and patients to some kind of active co-creators is the vision here. In a digitalized care system, the care won't be person-centric if the data is not. And this is something that the reality is that it is not. So we have to dive into this. We have to understand that we won't get this if we don't think about how we produce and consume digitalized knowledge, IA data. And just to zoom out a little bit, you probably know this icon. They have been around for about 15 years, and they have made some kind of digital twin for us. It's kind of a social digital twin. They know what we like and who we know, etc. These guys, the same, they have read all our emails, and they have know everywhere where we go on the internet, and they can propose which kind of cars we would like to buy or planes we would like to go with, etc., etc. And these guys also, of course, we are personalized, and we're also used to the fact that the services depend on the data that we provide, even if we want it or not. There is a richness in service that you could also, that's a good side of all this. If you book a hotel, of course you can know that they know that what happened, and not what happened, but they know who you are, and they know that you were here before, and you will get the same room if you want to, etc. It's same if you book a flight. There is also personalization, or a car. And as more data we provide, the better the matching gets. That's how it works. But how about the most important data regarding my own health? Well, we felt that we're kind of alone here as individuals. It's a total different ball game. It's a different universe than on the other side. Another aspect is me being a human being and understanding myself in a better way. If I compare we like to compare to machines. This is a system for control, services, maintenance of cars. In Sweden, we have this yearly checkup. You probably have it too. The car knows a lot about themselves. They have a preventive service scheme here that comes up, and you have the real-time idea of what's going on in the car with the tire pressures and all this stuff. So how would this apply for a human, which is a much more complicated machine, actually? To the left here, you have the simple machine, and here you have the complex machine. And what kind of maintenance system could I as a human get? What can I expect? Should I also have a prescriptive, predictive, preventive, or should I stay here in the reactive system that I'm in now? This is, of course, nothing new for all of us that work with health and prevention and therapy and all this stuff. But it's quite interesting when you want to approach this and see what can data and what can AI do in this, because then you start to discover this difference. And of course, there are many reasons for the situation why we are here. AI demands a new view on the purpose of data. We are used to digitalization, making apps, making electronic health records, etc. That's mostly about efficiency and effectiveness in the work process. Something different is a data-driven approach. because then you have to think about what kind of data do this special service or process provide. It's about knowledge production and consumption to give insight and decisions for all actors in the system. A data-driven approach for stakeholders like a caregiver, individual, and a researcher demands interoperability, as we know, and this combining value for each stakeholder as well as for the system as a whole. So how do we do this then? We use GDPR, the new upcoming EHDS, which is the European Health Data Space, and the private vault. I'm sure you have all met this GDPR stuff in different ways. Most of us, when you click OK to cookies, etc. There are obligations for organizations, for hospitals and states, how to protect us because this is sensitive data. And the implementation tools of this are widespread and are very implemented. But the rights for us individuals, for example, Article 15.3 and stuff regarding the right to portability and to retrieve your data, there are not many tools. There are not many implementations. And actually, there is not much compliance from organizations, from companies regarding that part. And this was a very central part when GDPR was created. And you remember, there were 30,000 lobbyists against GDPR protection regulation in Brussels those years. But now we got it, so let's use it. We have only started to use half of it. For our space, we will have a deeper level now with the European Health Data Space that really makes a possibility for us individuals and for organizations to get and access data on a totally new level, and that's coming now. So what we do instead too, we address the profound need for data ownership, the current situation where the health data is fragmented in apps and electronic health records is substituted with a private vault for your health data, where this is gathered, it's structured, and it's encrypted, very safe on the data atom levels regarding similar to the ICANN principle of cascading keychain clusters. This gives new possibilities for the individual to organize the data. You can collect your data in the personal vault, you store it here, you can find it fast. You will have a timeline where doctors' visits and medications and walks and swims and therapies, etc., are all spotted in, maybe viewed on a map, and also topics where everything around a certain topic, regardless of the data source, is organized like in a folder. And you can share it also. And this is a bigger part and will take longer time. But you could also import algorithms that you use in your vault without the data leaving, which I think will be a big thing. How is this done? Well, I connect my consumer devices, maybe if you have like an Apple Watch or something like that, or your MDR devices. Of course, you have to know in which context you do this. You could do this at home with like a blood pressure device, but it could also be in a hospital or other coach environment. And you create your digital health twin from this. This won't be any better than the data it gets. So therefore, we have to think about all this. Turning back to the previous slide, I was talking about the AI and the data-driven approach here. How the platform looks like. In the bottom here, you have the vault, which is a secure medical data storage. In the middle, to be able to connect this, you have the data broker for all the connections. And then as a user, you have a GDPR master client, which is like my health account, or a vault viewer where you have all this stuff regarding this. So 3 disrupted the benefits for the holistic aiming health space. The first one is that individuals could get a better understanding of their body and health situation, of course. The second one is that coaches and therapists that today work in a more analog way are not anymore excluded from the development in the digital arena. They can be included and they can benefit from technology by easy joining a digital twin ecosystem like the ones in the M4 perspective that Gunnar showed, thus enhancing their practice. I think this is really a good possibility. And also researchers, coaches, and therapists can get data that was not at all available before. Not only the data from care visits, but data from people's lives that really matter. Thank you very much.
Thank you very much, Jesper. And in the interest of time, we'll move on again to the next presentation, which is Kati Martinez. And she will talk about now when we have all of this data in the data vault, they come from different sources, though they are not compatible with each other yet. We need to make them compatible with each other. And this is what Kati is an expert on. So she will talk about how that is done.
So thanks, Gunnar. So I'm sharing my screen.
Perfect. It
So
works.
can you see my screen now?
Yep, it looks great.
Yeah, so first, thanks a lot for inviting me. Yeah, Dr. Noce and Cristina and the whole team. So I'm Catalina Martinez Costa from the University of Murcia in Spain. So working in medical informatics for more than 15 years and dealing with semantic data harmonization and semantic interoperability. So in Stratify, we have, as said before, we have data from patient EHRs. We have data from existing large databases and registries, from diverse studies. We have data collected by wearables. We have data obtained in clinical trials, data from mobile apps, such as patient diaries, and all of them are collected across different sources, and they need to be combined to be used by the digital twin. So they need to be used in two different scenarios. On the one hand, existing large databases are used to train machine learning models for predicting various aspects of the patient at different stroke phases. So, such as, for instance, the risk of having a stroke at prevention phase, the level of independence of a patient after a stroke. And on the other hand, as Jasper mentioned, we have data from EHRs, wearables, mobile apps that are used as input to these machine learning models. They are stored in this data vault and they are used to make the corresponding predictions and simulate different aspects of the patient. But this data comes from multiple institutions addressing the different phases of a stroke. They come from Germany, Spain, Switzerland, Romania, France, Italy, and they are really heterogeneous. Heterogeneous in many senses. So they are provided in different languages, with different degrees of structure, with different formats and different levels of detail. And in our project, clinical data cannot be integrated and physically stored into just a common repository within an institution due to ethical and privacy issues. So we cannot allow data to live in institution. and everything, including the training of the machine learning models, need to be done at each site. So here we have an example of the same data, so the same meaning, collected by 3 different data entry forms with different fields, so with different structure. The 3 register a patient diagnosis of suspected heart failure caused by ischemic heart disease, but in 3 different ways. Here also we have another example of heterogeneity, but here of some data collected about the level of independence of a patient for dressing and undressing, collected a different level of detail. So for instance, here, the assessment scale Bartel is used. This is from Spain. And here, 3 levels are provided. So it's indicated if the patient is dependent, half dependent, or independent. While for instance, if the FIM assessment scale is used, then only 2 levels are provided. So without help or with help. And the same with data collected by the Rikstroke Swedish Stroke Registry. So we need, in order to use all this information in an integrated way, we need to semantically harmonize it. And this is not just matching formats and extractors, but also ensuring that data meaning is consistent across sources. So if at one system we have a stroke diagnosis, and in another one we have it recorded as CVA, and in another one as cerebrovascular accident, we want to state that the 3 of them mean the same. And for that, key technology are ontologies. Yeah, probably you are not familiar with that, but in the context of healthcare, they enable to formally represent and sharing medical domain knowledge. So this is possible through logical axioms that define the meaning of concepts, and based on these definitions, they allow also the inference of new knowledge. So an ontology consists of concepts such as heart, blood, circulatory system, and relationships between these concepts. So for instance, the heart is a muscular organ that is part of the circulatory system. This is formally defined using a logic-based language in a similar way as we see here, in which we are saying, sorry for the Spanish, that the heart is a muscular organ and is part of the circulatory system. I don't know if you are familiar with the SNOMED CT, but this is the most comprehensive healthcare ontology-based terminology existing nowadays. So it contains scientifically validated clinical content, and it's multilingual. So it is used in more than 80 countries to represent medical content. And it's available in multiple languages, at least 17, and ongoing translation efforts exist. In addition, there are rules how to use this terminology together with existing information modeling standards, maybe some of them known by you, like, so very, very known in the medical informatics fields, like HA20, OMOP, and so on. So this makes SNOMED CT a great resource to allow this consistent sharing of data across sites. No? If we go back to the example of the stroke diagnosis recorded at the 3 different systems, if we annotate them with the code corresponding to the SNOMED-CT concept for a cerebrovascular accident, then we are stating actually that the three represent the same meaning. And if we have a deeper look into the formalization, so we see here graphically, so we in addition say that a cerebrovascular accident is a traumatic or non-traumatic brain injury, is a lesion of brain, is a cerebrovascular disease, is a cardiovascular injury. It's located in the brain structure, in the cerebrovascular system structure, and has morphology damage. So we are formally defining such concepts, what it's important to be interpreted later by a computer. But I wish it could be so simple and just using a code could be enough. But data need of contextual information to be unambiguously interpreted, and this contextual information is usually provided as answer to the questions when, who, how, what, why, and where. So in the example of the stroke diagnosis, so we may have the stroke diagnosis, but we want to know some contextual information about it. So when was it obtained? Who did the diagnosis? How was it obtained? So through a CT scan image, also CT scan. So why was this done? So maybe because the patient arrived with some speech difficulties, and of course, where is this located in the brain? So for representing this contextual information, terminologies and ontologies such as SNOMED-CT are used together with information modeling standards that I mentioned before. And there are many of these ones. So we have based on messages, documents, use of common data models, resources, and services. So very well known as FHIR, OpenEHR, OMOP. So, but then the question now is, what standard to use? Is this mass solution? So if I want to semantically harmonize data, should I just pick up one of these standards? It's done? Well, yeah, there are so many that usually what happens is that say, okay, I will now create a universal one that covers all use cases. And then you end up having 15 competing standards. Otherwise, so when each institution choose a different one, again, we don't have this interoperability. So what's the solution? So our approach in Stratify is ontology-based. So we are using ontologies as bridge across the different representations. What does it mean? That instead of committing to one standard, and that's all, so we represent all our data in FHIR, and we are done. So we put ontologies in the middle as bridge to allow this representation across different existing standards. And as said, we are doing this harmonization in two scenarios. So the first one, for training the machine learning models on the large existing databases. So in Stratify, we follow two steps. First, in order to harmonize all the data from these databases, we need to do a first data analysis and exploration phase, because harmonizing all existing data would be a tremendous work. So the first thing required is to allow analyzing and exploring data to find what are the relevant features or variables to build my machine learning model. So then first, what we do is provide this data analysis and exploration tool. Then, as mentioned before, due to privacy and ethical concerns, data cannot leave the respective sites, and we can only show aggregated values and statistics to modelers. Once these tentative relevant variables have been identified, the next step is semantically harmonizing them by using our ontology-based approach. So here we have just the main interface of the tool implemented to explore the data and select the relevant variables. This runs at each data source site and shows these aggregated values and statistics of the data. And then, as mentioned, once data is analyzed, and the relevant variables identified, we harmonize them by using our ontology-based approach, in which all data is mapped to our ontologies. And then, in this way, by using, so we allow machine learning models to be trained on each site, by using a technique named federated learning. Finally, in the second scenario, data is used, as mentioned, as input to the digital twin. Now, in this case, data from EHRs, wearables, and mobile apps such as patient diaries are securely stored in the data vault and then are later harmonized using our approach. And in this case, we are standardizing them using HA20 FHIR and SNOMED CT. So to provide this standardized interface with the digital twin. But of course, we could do it in another, using another standard, because as said, we don't commit to HA20 FHIR or to OMOP. So to conclude, in Stratify, we have the power of having a lot of data, but also the challenge to combine this data, from this that is very, very heterogeneous in many senses. And we have to combine this data and to integrate this data in two different scenarios. So one to be used to train machine learning models, and the other to use actual data from wearables, HRs, and sensors to inform the digital twin and simulate the different and do the different predictions. This data is spread across institutions with privacy restrictions. And then we had to implement everything on site and allow the aggregated data exploration and performing this data harmonization at each site. And the approach proposed doesn't commit to one specific standard, but is ontology-based. And this means that allows providing bridges between different standardized formats. So, and I'm not sure if we don't have time for questions now, but we can have them later in the round table. Thanks.
Thank you, Kathy. Thank you, Kathy. Yes, we'll take all the questions in the end. And we only have one more talk, and then you can ask all of your questions that you hopefully saved up by now. And we are going back to Romania, Simavi.
Hello.
So Simavi is the main developer of the electronic healthcare records in Romania, and they are a central partner of Stratify. They also help develop some of the apps, especially for rehabilitation.
So I know it's a bit late and maybe the energy level is not so high right now. So I'll try to be short on the presentation. I would like to add that we're honored to be part of this project. two words, let's say like that, about Simavi. We are a software developer in Romania. Let's say we are the leading house, and we are also an important player on the Central and Eastern Europe market. Today's presentation, thank you. Today's presentation is in the Stratify project from EHR to interactive apps. So we have an EHR. What is an EHR? It's an electronic health record, and it's a digital version of a patient's paper chart, basically. EHRs are real-time patient-centered records that make information available instantly and are securely to authorized users. EHRs are a vital part of health IT, and they can contain a patient's medical history, diagnosis, medications, treatment plans, immunization dates, allergies, radiology images, and laboratory and test results. They can also allow access to evidence-based tools that providers can use to make decisions about the patient's care, automate and streamline providers' workflow. So EHR records topics, example for a patient with stroke, example from Scuba Hospital. The EHR contains the following topics: patient's data, age, gender, allergies, urban environment, length of hospitalization, admission diagnosis, diagnosis at 72 hours, discharge diagnosis, reasons for admissions, background medication administered prior to admission, medical history, clinical examinations, and here I think that I will be correct, neuromyoartokinetic examination, assessment scales, paraclinical investigations, evolution, daily progression, speech therapy, physiotherapy recommendations upon discharge, therapeutic recommendations, medication treatments, and balneoclimatic cure. So the interactive application for physical rehabilitation. Physical rehabilitation app will be developed in order to help the different involved actors in the system's workflow to visualize the patient's activities, assessments, measurements, and simulations. An important part of information about the patients should be fed from the patient's EHR. Applications, the application features physiological data, activities definition, patients management, schedule activities, assessments, simulation visualizations, alerts, and reports. I'll pass this as we cannot access the links, but we'll have here a graphical user interface for the medical staff. To have an idea about how it would look like. This is the dashboard. For example, here we can see as you are greeted as the medic, as the doctor, and then you have the patients, which in this case is Julius Caesar. And you have, for example, steps, calories, activities completed, how many, 3 of 10. Statistics for the months, for example, statistics in February, completed activities, was the percent of the completed activities, the workout hours, other activities, overall improvement. There is also a panel with notifications where you can view all the notifications. Basically, the system does send you and lets you know about what should be done next. Also, this is the graphical user interface for the calendar, where you can see as a doctor what you have scheduled, with whom, when. So this should also help a lot and simplify the activity, as you can view all this stuff in one place. So basically, the doctor should focus more on the patient's care. with this panel helping you to schedule everything. Also, the notifications part, there isn't much to say. You can see here that you basically get the feed with everything that will happen, and the application does let you know. Also, you have this tab with My Patients, where you'll find the patients that you're treating basically, and with their gender, age, steps, calories, activities, and so on. And in the My Activities tab, you can also see here that you'll be able to name the activities types, how many patients are assigned to an activity, when was the date created for the activities, with some nice logos next to them. So the graphical user interface is pretty, let's say, user friendly. And that's the whole idea. And this is how you can set up activities. The interface, you can just click on add a new activity, and then you'll have it. You can name it, you can add a description, a recommendation, and it will show up in a panel. This is the graphical user interface for patients measurements. So this is the Stratify login screen where you can log in with your username, your password. And once you'll be logged in, you'll see a dashboard where you'll have your overall status. You'll have your calories, your steps. You'll also have a representation of the body for the body measurements, as you can see there. You'll have medications that you could click on and see what must be taken. For example, for the nutrition part, the calories as well, for your sleep time, for your mobility, the steps, the vitals. And also you'll have this activity tab where you'll see the overall. Basically, if you click on activity, you'll get to a screen, and then you'll see a little bit more information. Now, basically the interface is now a little bit in a higher resolution. So as I was saying, the body measurements, the health part, where you have your BPM, for example, resting heart rate, walking heart rate average, the medications, you have like a calendar for the days, the medication name that you can add. So basically, we focus to help and simplify all this process. Furthermore, again, in a bigger image, you have the sleep tab where you have your bedtime, your wake up time, how many hours you've slept. You have logs with everything like this. For the mobility, you can see your walking speed, your walking step length, walking asymmetry, and for the vitals, the overall status for the highest and lowest BPM for the heart rate, the blood glucose, the blood oxygen, blood pressure, body temperature, the respiratory rate as well. So you have functional classification scales, FIM plus FAM, self-care items, feeding, grooming, bathing, dressing upper body, dressing lower body, toileting, swallowing, sphincter control, bladder management, bowel management, mobility items, bed, chair, wheelchair, toilet, tub or shower, car transfer, locomotion, walking, or wheelchairs, stairs, community access, communication items, comprehensions, audio visual, expressing verbal and non-verbal, reading, writing, speech, intelligibility, physiological adjustment, social interaction, emotion status, adjustment to limitations, employability as well, cognitive functions, problem solving, memory, orientation, attention, safety judgments as well. So again, in the interface, in the Stratify interface, you can see the patient name. We have here John Doe, 19 days so far. And you can see you have a tab with the FAM. You can add a new assessment. In the self-care, you can see here feeding, grooming, bathing, dressing, upper, lower, toileting, swallowing, the date, and basically this is it from our end. Again, thank you, and we are proud to be part of the project, and we leave the questions for the end.
Okay, great. So now you have heard all of the presentations that we wanted to bring to you. So now there are questions, and we have one here.
The microphone.
I want to congratulate you both, your personal and your electronic avatar, for this interesting project. I'm not sure that I have well understood the semantic harmonization, because here in Romania, we use the Australian DRG classification when the diagnosis is made based on etiology, anatomopathological type, allergies, acute, subacute, or chronic stage. And I suggest not to reinvent the wheel, but to burn the time and shorten the, if it's a modest suggestion, if I have understood well this problem.
Yeah, so that's, I think, in part a question for Kati, who is online, who talked about the harmonization.
Yes, Gunnar, can you hear me?
Yes, we hear you.
Yeah, perfect. So I'm not sure if I understood you. So because of course, harmonization, so it's clear that data, it's collected in a different way at each site, in using different assessment scales. So we saw the sample of data about the level of independence of a patient for dressing or undressing, collected using different assessment scales. And there is the need to harmonize it, so to bring it into a common format, to be used by machine learning models. So that's the thing. When we have to combine heterogeneous things, we have to bring it into a common representation. And so it's not just data from Romania. So we have to combine it with data from France, for instance, if it's possible. I mean, if it makes sense from the point of view of the machine learning model. So then it's when we have to bring it into this common representation. So I'm not sure if this answers your question.
Yeah. So the Australian-based system that you say that you have here.
Yeah. So we use DRG, and it's very, very well systematized.
Yeah, and then there are probably lots of established connections between that system already and this Snowband CT, which is sort of universal standard. So there are probably lots of mappings already in place that we can use. I would assume so, Kati. Or do you want to add something, Professor Onosa?
Yeah, no, sorry.
Well, I shall say, continuing the idea of not reinventing the wheel, we can overcome such a hurdle because, on one hand, for the diagnosis, we have the International Classification of Diseases, which is absolutely universal. and is not connected to different details within our DRG Australian, which in a parenthesis has been taken in integrum. And so we have also some diseases like crocodile bite. Well, I close the parenthesis. But however, we have the international classification of disease, which is absolutely universal on one hand. And on the other hand, Kati, there is simple than more simple for harmonization, at least I mean for the rehabilitation work package with the clinical three settings, because we have all agreed to have just one single scale of assessment, and this is FIM plus FAM. Presented, we have given them to the Simavi, and she just presented it. So Christina presented, we use in the clinic more such assessment tools, GOS, ranking, etc., Bartel, but just for making it more simple, we adopted, we have been all, we agreed, Rory and Alejandro and Mao staff, to have just one single scale, which is with 30 items, as is completely covering from motor deficit to cognitive deficit to capability of swallowing, and including to social and work reintegration. So from this point of view, well, I'm a doctor, I'm not an IT, but in my modest opinion, this harmonization, at least for the rehabilitation, should be not very complicated if we accept, on the one hand, the ID, the International Classification of Diseases Diagnosis, and on the other hand, the single scale, which is most comprehensive and covering and unitary, the FIM plus FAM. I have also some other discussion, but this is for now.
And for closing this remarkable presentation, I want to make some history. Years ago, Professor Nos and all the team, we had a clustering project to observe and to follow up the patient with chronic spinal cord injury. And it was rewarded with a patent, was patented in a national patent. Unfortunately, we couldn't apply for different motives, but we had experience in this type of clusterization of data and working with information. Thank you.
So thank you for that question. So the floor is open, and we have just behind.
I'm really impressed and very happy to be there to hear you and to learn about that, because it is not my field. I am Patrick Carpentier from France, a vascular physician. One thing which I understand, which is really quite important for the future, at least I'm sure that will work, is the educational part. The patient with his twin can understand better, what you showed is really impressive. And I think this is certainly usable, and because people have to know their risk and so on and deal with that. And so you know what should occur in a statistical way when you have such and such risk factor and so on. So this tool has a very powerful impact, I think, for the person, and certainly that is useful as soon as it is available. Now I am more resistant to the real prediction, because as you showed on some of those slides, you don't have only the mean value, which is going up and down and so on, but you have also this uncertainty zone. And uncertainty zone for one factor is something, but when you combine 2, 3, or 100 factors, what about the final uncertainty? It becomes really challenging, and probably you will expect to have many errors unless you restrict the uncertainty zone, but that needs so many studies. It will be something really huge to achieve. So my question is, you have the tool. There are some models. Did you try to compare the real life of a patient to what was predicted by his twin? You have the patients, and you make a prediction through his twin, and you compare this prediction to what occurred in the patient 6 months later, for example. Did this kind of experiment has been done?
Yeah, so thank you for all the comment and very insightful question. We have compared with such data that is published, and we also used those type of studies where 6 months later what happened based on them changing their diet or something like this. The problem with most of those available data is that you know very little about what happened in detail during those 6 months. Maybe they started to go running, or maybe they had a life crisis, or maybe they got some other diagnosis. Lots of things can happen that can really impact what's happening. And those type of data is typically not available in available studies, in existing studies. So within Stratify, we will do an extensive study where we'll follow patients for 2 years, and where we will have certain windows where we measure very extensively what happens during a 2-week period. So they will come to the hospital for whole day examinations with lots of different trials, and they will be wearing different wearables for a 2-week period. We'll know exactly what they eat and when they exercise. And then they have several such windows during this 2-year period. And to some extent, we'll also know what they do between those intensive windows. And that is precisely to have these type of data where we know what they do continuously, and also to be able to compare the predictions. So to the extent that those data are available, we try to use them as best as we can. We try to collect the data that is not there, that is needed. But I agree with you in the beginning of your question that the most important and the most low-hanging fruit is just the pedagogics and the motivation and the increased sort of
Timescale project. Studies have to be done in the last part of the project, because the project has about 4 years. So yeah, there's a lot of time. We are only at the beginning of the project.
Yeah, so we were 1 year in out of a 4-year project. So it was a very good question.
Thank you. Thank you. It was fascinating. Thank you. You presented to us the better phase of AI for rehabilitation, because the twin will be, of course, a prodigious development of rehabilitation. But in our country, in France, the associations of disabled patients are questioning artificial intelligence as being in the situation to make harder the attribution, the allocation of means for rehabilitation, particularly for aging patients, and for adaptation for younger patients. Where have you some experience of this issue?
So should I take it, or do you want to take it?
Yeah, I can take it. This is a very good specific question, part of a general question. Would AI be a real advancement or maybe a threat? Of course, this depends on us. If we shall be so diligent and so clever to be always one step before the AI, we will use it in our benefit. Otherwise, of course, there is the risk of an unpleasant turn. But let's be optimistic, and I want to make some confessions. We have only 1 year practically since it entered in force, and our friend Professor Gunnar is so diligent. He is torturing in between brackets, you understand? Because we have every 2 months, every 2 weeks, Zoom conferences, and every 2 months, bi-weekly, and bi-monthly, and we keep it very, very, very tight. And although there are 4 years of this project, we are keeping it very, very tight in communication and monitoring the advancement. So there is a very important positive aspect, and this connects also with the balneoclimatology. Christina, wanting to frame perfectly in time, and she was very hurried, and she made an excellent synthesis, has spoken about the intervention, the physiatric intervention we are doing in our clinic, which is early neuro rehabilitation. That means we take in charge patients 7, 10 days, 14 days since the over supraacute event. Well, but these patients, as a good friend of ours, and we are very proud because he's also Romanian neurologist, Professor Dafin Mureșanu, who actually is the president of the European Federation of Neurorehabilitation, define such patients after a stroke hyperchronic. That means such patients never practically heal, and you never know how they will evolve. After 2 or 3 years, the deficit has been stabilized. The patient can walk with a crutch or independently, and he or she submit seizure, for instance. So such patients are hyperchronic, and the benefits of rehabilitation has to be kept and maintained. Otherwise, it's not a problem after 1 or 2 months or 3 months of rehabilitation. The patient reaches a status acceptable, and well, it's okay. For this, our job is finished. No, because afterwards, he or she needs monitoring, reevaluation, and last but not least, balneal cures. And the balneal and rehabilitation sanatorium in Techirghiol, together with the clinical hospital for rehabilitation in Păile Felix, which is in the opposite part of Romania, are the 2 most skilled units regarding including neurorehabilitation. So the idea of Professor Guna that this twin has to be able to monitor continuously or quasi-continuously, because in the diagram in the second slide, there was a very interesting observation. A patient can modify his or her evolution depending on what happens in his or her living style, in diet, including exercise, in getting more fat or slim. And this happens including in a balneal cure, because we have the 4 pillars of the balneal cure, which are the intervention of the physical, artificial, and/or natural cyanogenic factors, psychotherapy, group psychotherapy, nutritional education, and general sanitary education. And after such a balneal cure, his lifestyle changes. And nobody is very acquainted sharply to this modification. So the capability of communicating with the digital twin, because we have to face the patient practically, all of us can be monitoring him or her, but practically the patient is for sure with him or herself 24 hours and 7 days. So having the possibility to consult a twin, this would be a great success. And I don't want to be long in my intervention. I want to highlight 2 aspects. First of all, there are also threats and limitations. And one of the member of our consortium, Professor Bichenbach, who is a lawyer, acknowledged us that I think very soon, if I understood correctly, next month, in a week, there will enter in force the European Union directive regarding GDPR with restrictions for AI. We shall see. Well, practically, we have already obtained the approval for the Bioethics National, at least Romanian Commission, but we shall see. This is a problem. How much restrictive will be regarding AI, their regulations of the European Union is the first regulation worldwide regarding artificial intelligence of the European Union. And secondly, wishful thinking. Probably Professor Gunnar has enough of my insistence. All this very, very advanced IT endeavor should result in a dialogue, in my opinion, by voice with the twin. The endless click, 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 you choose a click, 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 choose from the menu, click, 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 I think is very chronophagic and practically is a very traditional way of using the computer. This would be an excellent advancement that all this questionnaire, which as you have seen, is very detailed because we want to know as much as possible from the patient, should be able to be carried on with the patient by the twin. Maybe I dream too much, but however, I insist upon that, and we shall see. Of course, we are at the beginning of this wonderful project, and I want once more to thank very much to Professor Gunnar Pedersen. He is constantly inspiring us, and his presence here is a guarantee of a good roadmap of this project. Thanks to you.
So we are already 10 minutes past. Maybe that is the wrapping up. What do you say, the organizers?
Maybe one conclusion for the station, because after that we go to the networking.
Yeah, and we can of course keep discussing over some.
Maybe as an answer to the professor wish about the voice, using the voice. Maybe.
Yeah. So I think this is a great example because you raised those concerns a couple of months ago when we had the first outlines. And since then, our software developers have taken that in. So currently, we have a ChatGPT-like interface, so you can talk in a very free way to the app. You don't have to click and drag and drop and fill in. You can talk as you do to a friend, and then it will pick up all of the information that's needed from your conversation.
There are very largely used already. Instant translators.
Yeah, exactly.
So communication is very well now free and facilitated.
So thank you very much. The session can be closed here, and we see you in the welcome cocktail, which is in the same place as it was the opening ceremony. Thank you so much.